Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the neurology, that is the Brown-Séquard Syndrome. So what exactly you understand by this Brown-Séquard Syndrome? Brown-Séquard Syndrome, it is the disorder which is characterized by hemisection of the spinal cord. Right, so that is the meaning of the Brown-Séquard syndrome, where there is hemisection of the spinal cord. Now, this is how the questions can be asked on the topic of Brown-Séquard syndrome, that is, the type of sensation lost on same side in Brown-Séquard syndrome is pain, touch, proprioception, temperature. So we will discuss and then come back to this question. So this is the spinal cord, right? So you can make out here, this is the hemisection of the spinal cord. So you have to understand that within the spinal cord you have the tracts. And what are these particular tracts which are being present? That is ascending and as well as the descending tracts. Right, ascending and as well as the descending tracts. So if you take the descending tracts include the corticospinal tract, which is also called the pyramidal tract, right? And this particular pyramidal tract, it will cross at the level of medulla oblongata and then it descends downwards. Whereas ascending tracts, if you see, that includes spinothalamic tracts, followed by that dorsal columns, next followed by that spinocerebellar tracts. These are the ascending tracts. And you take the spinothalamic tract, it will cross to the opposite side at the same level. It will cross to the opposite side at the same level. Whereas dorsal columns, they cross at the level of the medulla oblongata. And spinocerebellar tracts, there is no crossing to the opposite side. So what you have to understand here now is, for suppose in this image, if you make out that right side of the spinal cord has been cut. So when the right side of the spinal cord has been cut, which side tracts are gone, I'll explain you. Spinothalamic tract of left side is damaged because at the same level it will cross to the opposite side. And dorsal columns, DC stands for dorsal columns, SCC stands for spinocerebellar tract, right? So spinocerebellar tract and dorsal columns, both of them, they will be of same side. And what about the corticospinal tract? The corticospinal tract, which is supplying on the right side, is being cut. So accordingly you should know the manifestations now. So whenever there is hemisection, spinothalamic tract of the opposite side, dorsal columns, spinocerebellar tract, corticospinal tract of the same side is being cut or damaged. Now what will be the clinical features of Brown-Séquard syndrome? So if you take the clinical features of the Brown-Séquard syndrome, you need to know what will be the features of Brown-Séquard syndrome. If there is lesion, that means below the site of lesion, what will be the clinical features? At the site of lesion, what will be the clinical features? And again, below the site of lesion also, you should know what are the motor changes and as well as what are the sensory changes. You take the motor changes. Below, and always remember, I'll tell you one important points point here related to spinal cord lesion. At the site of lesion or at the level of lesion of the spinal cord, the features that you will have is lower motor neuron type of motor manifestations will be there. Whereas below the site of lesion, upper motor neuron type of the motor changes will be there below the site of lesion. So you take the motor changes. Below the site of lesion, you have the features of upper motor neuron, which is nothing but the pyramidal tract lesion features will be there. Okay, so the motor changes, these changes are due to interruption of the pyramidal tract. Right, interruption of pyramidal tract. So what will be the features of the pyramidal tract lesion? The features of the pyramidal tract lesion include, number one, there will be Babinski sign, right? That means there will be upgoing plantars on doing a plantar reflex. Then spasticity will be there, that is hypertonia, and there will be increased deep tendon reflexes, and there is also loss of abdominal reflex. So these will be the motor changes below the site of lesion. And you take the sensory changes. Ipsilateral side, what will be the sensory changes? Contralateral side, what will be the changes? Ipsilateral side, what are the tracts which will not cross at the same level and which will pass on the same side? That is dorsal columns and as well as the spinocerebellar tract. So on the same side, you will have the features of dorsal column lesion, you will have the features of the spinocerebellar tract lesion. And what will be those features? See, dorsal columns, they carry the sensations like fine touch, followed by that tactile discrimination, next followed by that loss of vibration sense, right? So these are the sensations being lost whenever there is damage to the dorsal columns. So on the ipsilateral side, you will have the features suggestive of loss of dorsal column sensation, right? Features suggestive of loss of dorsal column sensation. And you also have the features suggestive of spinocerebellar tract lesion. And on the contralateral side, what will be the sensory changes? On the contralateral side, the sensory changes that you will have is the features suggestive of lesion due to spinothalamic tract. Spinothalamic tract, it will cross to the opposite side at the same level. So left-sided spinothalamic tract will cross on to the right side. So if there is right-sided hemisection, you will have damage of left-sided spinothalamic tract. So contralateral side, you will have the features suggestive of loss of spinothalamic tract. And what will be that features due to loss of spinothalamic tract? That is loss of pain, temperature, and as well as the crude touch. Right, loss of pain, temperature, and as well as the crude touch. So that will be the features you will have on the contralateral side. So these are the manifestations below the site of lesion. At the site of lesion, what will be the features? Right? So if you see at the site of lesion, you will have motor changes and as well as sensory changes. Motor changes, if you see, that is mainly due to loss of anterior horn cells, right? That is due to loss of anterior horn cells of the spinal cord. So anterior horn cell, it is a lower motor neuron, right? It is an element type of cell. So these individuals, they'll have lower motor neuron type of paralysis, right? They'll have lower motor neuron type of paralysis, okay? That is at the site of lesion. And what will be the sensory changes at the site of lesion? That is due to loss of posterior root of corresponding segment. Right, that is due to loss of posterior root of the corresponding segment. So the individual will have anesthesia on the ipsilateral dermatome. Right, anesthesia on ipsilateral dermatome. So these will be the sensory changes at the site of lesion. So below the site of lesion, the motor changes will be upper motor neuron features. Sensory changes will be ipsilateral side, dorsal column sensations lost and spinocerebellar tract sensations lost. Contralateral side, spinothalamic tract sensations are lost. That is below the site of lesion. At the site of lesion, the motor changes will be in the form of lower motor neuron type of paralysis. Sensory changes will be ipsilateral dermatomal pattern of sensory loss will be there. So these are the clinical features of the Brown-Séquard syndrome. Now, so if you see this question now, type of sensation lost on the same side in Brown-Séquard syndrome is pain, touch, proprioception, temperature. Pain, crude touch and as well as temperature. All these are carried by spinothalamic tract which are lost on the opposite side. Whereas proprioception, it is being carried by dorsal columns and as well as the spinocerebellar tract. So on the same side, the sensation which is being lost is the proprioception. The next question is, the following are the components of Brown-Séquard syndrome except ipsilateral extensor plantar response, ipsilateral pyramidal tract involvement, contralateral spinothalamic tract involvement, contralateral posterior column involvement. So ipsilateral extensor plantar response will be there, that is due to lesion within the pyramidal tract. Ipsilateral pyramidal tract involvement will be there. Contralateral spinothalamic tract involvement will be there, but contralateral posterior column involvement will not be there. You will have ipsilateral posterior column involvement, right? So the following are the components of the Brown-Séquard syndrome except, the answer is D, that is fourth option. Next, a ventrolateral cordotomy is performed to produce relief of pain from the right leg. It is effective because it interrupts the left dorsal column, left lateral spinothalamic tract, right lateral spinothalamic tract, right corticospinal tract. So a ventrolateral cordotomy is done to produce the relief of pain from the right leg. So on the right leg you want the relief of pain. So the pain perception is being carried by your spinothalamic tract. The spinothalamic tract, first it enters into the right half of the spinal cord and immediately it crosses to the left side. So where should you do the cordotomy? You have to do cordotomy on the left lateral spinothalamic tract. So when you do a left lateral spinothalamic tract, hemisection, then you will have the pain relief on the right side of the leg because spinothalamic tract will cross to the opposite side. Then, how do you treat these patients with the Brown-Séquard syndrome? See, most of the times Brown-Séquard syndrome is secondary to injury to the spinal cord. So what will be the treatment of the injury? It consists of, number one, immobilization. Right, number one, immobilization. Number two, if there is cord compression, then you need to start early decompressive laminectomy. So, decompressive laminectomy has to be done, right? And this decompressive laminectomy, it will relieve the pressure on the spinal cord, and this has to be done within 24 hours. Right, this has to be done within 24 hours. So that is what is the treatment of the Brown-Séquard syndrome, that is decompression. Then what is the role of the corticosteroids? See, early treatment with high doses of corticosteroids, right? So you need to give high dose of steroids, and the steroid that you have to give is methylprednisolone, and this methylprednisolone should be given at a dosage of 30 milligrams per kg, and you have to give this through intravenous route, right? Intravenous bolus. Then followed by that, you need to give 5.4 milligrams per kg. You have to give for 23 hours, right? So that is about the methylprednisolone, and this methylprednisolone will improve neurogenic recovery, right? This will cause the neurogenic recovery, and you have to give this particular steroids within 8 hours after the injury. Right, within 8 hours after the injury. So that is about the role of steroids. So which will cause the neurological recovery if it is given within 8 hours after the injury, right? Then followed by that, anatomical realignment of the spinal cord by traction and other orthopedic procedure is also very important, and you need to take the subsequent care of residual neurological deficit, if at all, if it is there, you need to take care of it. Paraplegia or quadriplegia requires treatment of spasticity and care of skin, bladder, and as well as the bowel. So this is about the treatment of the Brown-Séquard syndrome. So to summarize Brown-Séquard syndrome, it is a disorder which is characterized by hemisection of spinal cord. In these patients with the Brown-Séquard syndrome, you will have ipsilateral corticospinal tract lesion features. That means you have to divide it into, at the level of lesion, what will be the features, below the level of lesion, what will be the features. Below the level of lesion, the motor manifestations will be the features of pyramidal tract, and sensory manifestations will be on the opposite side. You will have features of spinothalamic tract loss, and on the ipsilateral side you have the loss of dorsal columns and as well as the spinocerebellar tract, that is below the site of lesion. At the level of lesion, the motor manifestations will be lower motor neuron type of manifestations will be there, and sensory manifestations will be ipsilateral dermatomal sensory loss is being there. So these are the features of Brown-Séquard syndrome, and this completes the discussion of this very important topic, that is Brown-Séquard syndrome. Thank you very much.